Good afternoon, everybody, and thank you for inviting me. I have a couple of quick disclosures. One, Loma Linda is in Southern California, so it was about 90 degrees when I left. So my greatest challenge this morning was walking from the hotel without killing myself. And my second disclosure is that my dog is actually named Ginger. And so after you see our after-visit summary, I may be the embodiment of the Gary Larson cartoon. But I wanted to give you a little bit of idea what I'm going to talk about. I'm going to talk about how we developed our AVS and the format that we developed, and then give you some of the features that kind of go beyond the meaningful use that we feel are actually more patient-centered and exceed the kind of expectations that are out there right now. Well, the Veterans Health Administration is actually the largest health care system in the nation, and I want to point out that VHA is actually a division of VA. VA consists of the cemetery benefits and then the healthcare division. So we serve over 8 million enrollees and 85 million outpatient visits in 2012. And the majority of physicians in the United States have trained, at least in part, through VHA rotation. So they've been exposed to our electronic health record and our systems at the VA. And I never want to miss the opportunity to point out that most of the studies show that VA care is very good and that the VA consistently outperforms the private sector in both quality measures and patient satisfaction. Who are our patients? Well, they tend to be an older, sicker, and poorer population when compared to non-veterans. Although their education levels are about the same as non-veterans. And the demographics are changing over time, of course. When I came on the VA about 22 years ago, most of the patients were World War II veterans that were in their 60s and 70s. They've mostly moved on now. And we have more and more patients from the current conflicts and an increasing number of female patients as well. Well, the VA has a electronic health record that's integrated throughout the entire system, that it's been received quite a bit of notoriety. It's based on VISTA, or the Veterans Information Systems and Technology Architecture, which is actually written in MUMPS, which is kind of an old language, computer language, although I found out today from our EPIC colleagues that EPIC is also written in MUMPS code, so it's very sustainable and very flexible, and the VA has leveraged it to develop, I think, a very robust electronic health record. Around 1998, the VA introduced a computerized patient record system, which is sort of the GUI graphical user interface for VISTA, so kind of the user-friendly face of VISTA. And this has been recognized with awards and ranks very highly amongst providers. What both CPRS and VISTA actually developed from innovations in the field, from clinicians giving direct input into developing this electronic health record. And there's been times in the VA's history where it's become more centralized and VA has kind of taken control and say, no, we're not going to allow any more innovation. We're kind of going through one of those phases right now. VA owns the Office of Information Technology, and so they are the ones who kind of dictate, what goes into CPRS at this point. So, but VA is also seeking meaningful use certification. Although we can't take advantages of the CMS incentives, VA wants to have CPRS recognized as meaningful use certified. So what is the VA AVS? That's it. If I had crickets right now, I would let them play because we don't have one. Probably it's, I would say, a couple of years away. And because all the development has become centralized again, it's a very slow-moving process. And so we have not caught up with the private sector in this area. So what has happened is people do workarounds. This is an after-visit summary that I created a number of years ago that actually is just an output directly from our electronic health record, CPRS. And you can tell it's not very user-friendly like many of the examples we've seen earlier. Even worse, a lot of my colleagues use pen and paper sorts of workarounds. So this is actually what spurred me to develop an after-visit summary. Is after going to my own private physician way back in 2006, I received a very good after-visit summary. and was really disappointed that the VA didn't have anything like this. So our goals for developing after-visit summary, obviously to make a patient-centered clinical summary, but also we wanted to balance this with minimizing the work for the providers. I have to say that in the VA, I think there's a huge clinical computing burden that physicians are very much at the center of. It's very physician-centric in terms of both retrieving and entering data into the computer. So to introduce something like this where it never existed, there had to be some balance and to automate some of this as much as possible, but still make it as patient-centered as possible as well. So just to give you an idea of our software development timeline, one of the ways that VHA is working around the VA's control over CPRS right now is to have innovations in the field. So they have an innovation program, and we received a grant in 2009 to develop the after-visit summary. And then it took a few years to do that, and it sat on the shelf for a little bit. But in 2012 and 2013, we tested it live, pilot tested, if you would, on live clinicians in our live account. And since then, it's now been deployed at 6 additional VA sites, including Loma Linda, where it went live about a year ago. And we've engaged a number of groups within VHA, including med reconciliation and meaningful use groups, to further expand on what's in the content of the AVS. So just to give you an idea of our software development cycle, and we don't really have a formal software development cycle at Loma Linda, but I think that's an advantage to us in a lot of ways, but probably is unique in a lot of ways as well. So I work, myself and my informatics team, we work very, very closely with a very talented programmer. He is a physician by training. He didn't go through his postgraduate training. He decided to go into programming. And we give him direct input about what needs to be in the AVS or other projects that we're working on. He develops it. We bring it right back in and test it. So we did the prototype development with our programmer, our local programmer, and a contractor. And we used focus groups for both the veterans and physicians, got some input, and developed the prototype. And then from there, we've just been in a continuous cycle of iterative development with the clinicians and the front lines actually using the tool and giving feedback to the programmer. And that includes the 6 sites that we've now expanded to as well. So the content development sort of went from this basic prototype with the basic data and what was feasible to a more expanded layout and more aesthetically pleasing AVS. And then as we got more groups involved, additional information it came into the AVS. Of course, the disadvantage of having not such a formal cycle is that releases to the field, if you will, can go out with some bugs. But some of the advantages to having not a formal style of software development is that we can fix those bugs very, very quickly. Another disadvantage, though, is you kind of get scope creep, right? So many people have so much input into the development that you wind up going way beyond maybe the requirements that you had planned for. But it's certainly less rigid than your classic software development cycles. Well, it isn't all about IT. I don't want to scare you with this slide. But what I wanted to emphasize here is that the AVS actually resides outside of CPRS. You see CPRS over here. But the AVS is actually on a server that's external to CPRS. And that's really one of the most powerful things about it. It allows us to leverage the data that's in our electronic health record, but also to reach out to other sources on the internet to expand the data that's in the AVS. So this is the clinician's view of the after-visit summary. Actually, what you're seeing there is CPRS. But the after-visit summary is invoked from this drop-down menu. And once it's open, it's what we call CCOW, or Clinical Context Object Workgroup compliant, meaning that as I change patient selection in CPRS, the after-visit summary changes patients as well. Once it's opened, the AVS comes up in a browser, and it looks basically like the PDF that's going to be printed out for the patient. It auto-refreshes every couple minutes, so as the provider enters orders or information into the electronic health record, it's auto-refreshed and it's automatically populated with that data. The workflow around this is important, as people have pointed out. It's actually critical, and that is if for this to work optimally for the patients, the orders and the encounter form have to be completed before it's given to the patient. So the formatting, the structure of it is something we developed at the beginning and sort of stuck to, but was basically information from today's visit, other important information that we entitled important notes, and then my ongoing care. And so we wanted to separate what happened today to what's coming up and what's kind of your ongoing care that you typically get. And then I've listed the meaningful use criteria that we've addressed and put under each one of those main categories. You notice that I don't have a check mark by the problem list because we actually populate the AVS with the diagnoses from the encounter form. So I don't know about your institution, but the problem lists are abysmal at mine. So we actually use the encounter form to populate that part of the AVS. And then the other two sections, today's visits and important notes. I put a plus minus by the care plan field because we haven't really worked out totally how to incorporate the goals, the patient's goals in there. And I think that's more because of a cultural change rather than a technical issue. And then we added remote appointments, which I'll show you in a moment. And then my ongoing care section. And I'll elaborate on some of these extra things that we added in here. So a lot of patients in the VA are snowbirds. They come to Southern California, for example, and they live somewhere else the rest of the year. So we wanted to be able to bring in their remote information as well. So this patient in the after visit summary, and by the way, there's copies of it out there if you want to look at it, but this is a real patient of mine. And he goes back to Seattle area for the summer, spring and summer. So here's his upcoming appointments up at Puget Sound. And would also display, of course, his local appointments in Loma Linda. We included our primary care team. The VA has something similar to the patient-centered medical home. It's called PAC, the Patient-Aligned Care Team. So we can include, here are just the LVN and care manager, but there's others, social worker, pharmacists that can be included as well. We also included visual descriptions of the patient's medications. As we all know, our patients identify medications by the way they look. So we include this visual description. We've also entertained and looked at, and it's technically possible to actually bring the photos of the medications in themselves. But there's some barriers there in terms of printing and making the after visit summary longer that we haven't completely wrestled with yet. We also provide for reconciling the remote medications. So you see the after visit summary here is if a patient was seen at another VA or had prescriptions outside the VA that were recorded in CPRS, when the provider goes and opens the after visit summary, they get this interactive list and it asks them to check off the ones that the patient's actually taking from the other sites so those can be reconciled. And then it prints out like this, and maybe a little bit hard to see, but you can see in the handout, but it says medications from that were not from the VA, medications from the other VA, and then there's subcategories on there, the ones you reported you were taking and the ones you are not taking, and then there's a note there to the patient on the ones you're not taking, please clarify this with your outside provider. The AVS has a number of other customizable features, and I'll elaborate on a few of these here, but we are trying to translate this into Spanish. We haven't completely finished doing that yet. And also there's an option to toggle on and off the various sections of the AVS, depending on what the provider wants to display to the patient. We have an increased font size for the visually impaired, so there's kind of a normal font, large and very large. We included charts for trending clinical data. And part of this is just anecdotal that when we show patients their clinical data in CPRS, they really like to see it on the charts. So we thought, well, we might as well try and include this in the after visit summary. We have clinical service locations, hours, and contact information. So the provider can select different services that the patient might be going to, or actually lists them all, but it basically lists the hours, the location, and any other contact information and special instructions. We also integrated it with patient education material that we use Crames on Demand. And so there's a button on the AVS to bring this up, but the education sheets that are recommended there are based on the ICD-9 codes that were entered in the encounter form. And then that material can either be incorporated completely into the AVS, or sections of it can be copied into the AVS, or it can simply be printed, in which case then the AVS automatically dumps into the instructions, which is kind of a freehand instruction area, that please read this article from Crames on Demand. Or the text can go in, copied text can go in that same section of the AVS. We actually have a translator built into it so that jargon from Vista that's not very patient-friendly can be translated. And so in this case, I just took PM&R and changed it to physical medicine and rehabilitation, so then all subsequent after-visit summaries will have that translation built in. And then once the AVS is selected for printing, there's what we call a stub note created in CPRS that just indicates the note is there, but the actual AVS itself is stored as a PDF in our imaging software. So we tried to take the after-visit summary and build on the meaningful use criteria and add several other things to hopefully make it more patient-centered and useful to patients. But it also requires some evaluation. So that's something that we're looking at. And as mentioned, I have a small grant to look at that, and I'm developing another grant, a more extensive grant. Just to give you an idea, I found one article that was very recently published that was a randomized controlled trial, looked at 4 different after-visit summaries that varied in terms of content and length. The longest one was actually the one that had all the meaningful use criteria, and they found no difference in satisfaction amongst the groups or in content recall. They actually found that health literacy also did not affect medication recall. Of course, other studies have shown it does. And the patients in general did not place a lot of importance on the formatting. The other thing out of that study was that the vast majority of the patients wanted a printed copy when they left the office. So we plan to kind of look at these same sort of things in terms of veteran preferences, including some of the additional features that we've added to the AVS. And then finally, other future directions, we're actually working on a pre-visit summary. So to provide the patient with a list of their medications to facilitate medication reconciliation, but also an area that they can write down their concerns for the day and also show them their clinical reminders that are due. And then we're working with the Veterans Portal system, which works on patient kiosks where the AVS and pre-visit summary could be interacted with by the patient on their own at a kiosk outside the clinic. So that's pretty much all I have. Thank you.